Good morning everyone. So today we are going to learn about salivary gland disease number 2. It means we are going to learn about the neoplasm of the salivary gland. Unfortunately, with the salivary gland, it's going to be quite complicated with the neoplasm. But you have to know all the important things before we go deeper. So before we go to the histology part of the salivary gland, you have to know the clinical part. Very, very important, because for your level, you have to know is it benign or malignant neoplasm. Okay, so from the history of the patient, you have to ask the patient if the lump has rapid growth, is the lump associated with any numbness, pain or facial paralysis. If the growth is very rapidly, so you know it's a very good clue that is something which is malignant or aggressive. And if it's associated with numbness or facial paralysis too, it means because it's invading the nerve. So that's why you have to ask these important questions, then you will be able to know if it's malignant or benign. Okay, and then after that we go to the physical examination. You have to check the cranial nerve, see if there's any cranial nerve palsy, because usually with salivary gland, especially the parotid gland, is very near to the 7th cranial nerve. And then you have to check for neck node enlargement, the lymph node enlargement. You have to know what is the etiology of the lymphadenopathy. Is it because of infection or it's because of neoplasm? So you have to know the consistency, the fixation of the lymph node. Usually if it's hard, rock hard, and it's fixed, then you know it's something which is malignant. And also you have to search if there's any distant metastasis. So is there any other lump near to the salivary gland? Or is there any submucosal swelling, especially if it happens in minor salivary gland? Then we can go, after that, we can have the radiographic examination. So basically you have the history, and then you have the clinical examination, and then we go to the radiographic examination. The cheapest one is ultrasound, but unfortunately it depends on the skill of the operator. It means for you to send the patient for ultrasound examination, you need to have a very good ultrasound. It means or any radiographer that good with ultrasound, because it depends on their skill. So beside the physical examination, then we can have the ultrasound because it is low cost. Okay, and then it is recommended as pre-operative examination because we want to know the extension of the neoplasm. And then it also very good to differentiate between is it intraglandular, is it inside the gland or is outside the gland. Okay. And then there are other imaging, which is the CT scan and MRI. You know it well. So CT scan is very good for the bone and MRI is very good for the connective tissue. So basically, if you think that's any extension into the bone, then you can order the CT scan. And also, if you want to know how big or how aggressive it is, then you can order MRI. But unfortunately, MRI is very difficult for you to get access. Okay? So, if it's minor salivary gland, especially on the palate, then you have to ask for CT scan because it involves the bone, the palate, the nasal cavity, nasopharynx and paranasal sinuses. Okay? Okay. So this is the example of the CT scan. You can see in CT scan, the bone will look more opaque. Okay. So this is the mass. Okay. It's from the parotid gland. Okay. So this is another one from the parotid gland. Okay. So this is the CT scan too, because you can see the bone here, and then this is the mass. Okay. So after the radiograph, then we can go to the invasive one, which is biopsy. So usually with salivary gland, we don't do excisional biopsy unless if it involves the minor salivary gland, because the size should be smaller. But if it involves the bigger salivary gland, for example, parotid, submandibular, sublingual gland, then we use the fine needle aspiration. With the fine needle aspiration, it helps, okay, to diagnose if it's malignancy or benign, okay. But unfortunately, it's not the golden investigation. Why is not the golden investigation? Can you imagine when we aspirate the cells, then the cells might be a little bit distorted. So that's why it's not the golden investigation. So at first, usually we'll do the FNA cytology. We just have to know, we want to know is it malignant or benign, okay? Or we can know is it because the origin is either salivary or lymph node, okay? And then after that, when we open the surgery, we do open surgery, then we can do the excisional or incisional biopsy. Then we have the golden investigation because the cells will not be distorted. Is it very clear, guys? Okay, so that's the biopsy. So this is the fine needle aspiration. It will be long and quite big, the needle, the diameter of the needle. So we can aspirate the cells inside the needle. Okay. Because usually if it's big and major salivary gland, we cannot do excisional or incisional biopsy because there are so many important structures around it, especially the parotid gland, because there's nerve and big arteries over there. Okay, so you can have the staging of the cancer. Basically, it's quite the same with the staging of the cancer of the squamous cell, SCC, squamous cell carcinoma. So this is the primary tumor classification. It depends on the size of the primary tumor. For example, you have a mass on the parotid gland. So the size of the mass will determine the primary tumor. So it will written as T. Okay. And then it depends on the lymph node. So how big the lymph node. Okay, so that will be the N. And then the last one is the metastasized, M. So if the neoplasm already metastasized to other areas. Okay, so this is the one, stage 1. So and then, so you have T and M. Okay, so this is the staging. After you get the T and M, then you can stage it. It is stage 1, stage 2, stage 3, stage 4, A, B, and C. Okay. Okay. So what is the prognosis of the salivary gland neoplasm? So it depends. There are so many things which are counted for the prognostic factors. For example, the tumor stage. So what is the staging? Is it stage 1, 2, 3, just like just now, 3A, B, C. The histology, the grading. Okay, the grading, the difference between tumor stage, staging and grading is the grading depending on the histology. Okay, is it very aggressive or not? Is it involve the facial nerve? Okay, the extension of it and the cervical node involvement. Basically, this is the staging. Okay, so the facial nerve paralysis, the extension and cervical node involvement is part of the staging because that's the metastasized part. So these are the important factors that you can come to the prognosis of the gland. Okay, so can you see? Okay, there's a swelling on the palate there. Okay, at first there's no ulcer, but after a few weeks, it became bigger and it became ulcerated. Unfortunately, it's very rare to get salivary gland neoplasm on the palate. But if it's on the palate, it means it's something which is red flag. It's something which is very, very bad going on. Okay. So we'll go one by one. So I just want to remind you, with salivary gland neoplasm, it's going to be it's quite tough, the histology, okay, because it just look quite the same. So you have to know the clinical part of it better, and then you have to know the important points for you to grab what the diagnosis for the salivary gland neoplasm. If you look at the cells one by one, it may be confusing, but you have to look overall architecture and also pattern histologically, okay? So it's going to be really confusing. So in salivary gland neoplasm, most of the time we are going to use extra staining to help us. Okay, so we'll start with the salivary gland neoplasm. So salivary gland neoplasm, it has diverse histopathology because you know in salivary gland there are so many cells. You have mucus acini, you have serous acini, you have the myoepithelial, you have the epithelial, so it has diverse histopathology. It's quite uncommon, 2% of the head and neck neoplasm, because the most common one is squamous cell carcinoma. The distribution mostly is in the parotid, okay, and fortunately it's benign. Submandibular is the second one, and then it's also benign. Sublingual, it's quite rare and it's benign, but it's more prone to have malignant tumor in minor salivary gland. Okay, so the etiology, so it's multifactorial. We don't really know. They said the diet is effective in preventing the salivary gland cancer. So that's why you have to eat lots of fruits and vegetables, especially those with high in vitamin C. And you have to prevent yourself from eating fatty and high cholesterol food. Red meat, so you can eat it, but it's not quite good for you. It actually cannot prevent the cancer from happening. Okay, so there's a case control study in Chinese population. They said dark yellow vegetables or liver, but I'm not very sure about the liver, but it mentioned as liver, it can reduce the risk of salivary gland cancer. And the most important thing is irradiation. It means if there's any radiation before, for example, if you have any thyroid radiation or around head and neck radiation because squamous cell carcinoma, then you have to search. You have to review the patient in long term because you're scared that the salivary gland neoplasm might be happening. Okay, so the risk factors, if there's history of prior cancers, history of radiotherapy, so that's why radiotherapy of the head and neck is very important. You have to ask the patient if they have any radiotherapy of head and neck before. The patient with immunosuppression, HIV patient, or even if the patient is taking any immunosuppression, for example, because they have some transplant. Epstein-Barr virus, yes, virus can increase the risk of cancer and radiation. Okay, so the classification we have its origin from the epithelial or non-epithelial, and we can classify is it benign or malignant too. Okay, so this is the latest WHO 2017 classification of the salivary gland neoplasm. So basically there's some regrouping and new entities. Okay, you see there are so many. Basically this is based on the histology. So this lecture, I'm just going to highlight all the most common and the neoplasm that you have to know. For example, pleomorphic adenoma, Wharton's tumor, okay. And then this is the malignant one, okay. This is secretory carcinoma, is new entities. And there's a lot of simplification terminology, which is great because if not, it just make you more confused, and there's regrouping of the rare entities, okay? So please do not worry about that. I'm just going to go through all the important and the most common neoplasm that you have to know at least the basic things. Okay, for example, in epithelial one, okay, we have benign that you have to know pleomorphic adenoma because it's very, very common. Okay, pleomorphic, it means it's just multiple or the various of the stroma, and monomorphic means it's just one. Okay, mono and pleo, you know it. So for example of monomorphic adenoma is Wharton's tumor and oncocytoma. For malignancy, you have to know adenoid cystic carcinoma. Okay, mucoepidermoid carcinoma is very important because that's the most common malignant one. Carcinoma in pleomorphic adenoma, X carcinoma. Okay, actinic cell carcinoma, adenocarcinoma, and undifferentiated carcinoma. So this is the most common one that you have to know. So pleomorphic adenoma, Wharton's tumor, oncocytoma, mucoepidermoid carcinoma,